Now we will continue with the clinical features of GB syndrome. We will see how the syndrome is going to affect our body, what parts are damaged initially, and how it progresses and ascends to other parts of the body. So we will talk about the signs and symptoms, the initial signs and symptoms with which the patient presents, and what are the later features with which patients can present with GB syndrome, and how we will diagnose the patient if he's experiencing autonomic involvement. So first of all, we will see the risk factors of GB syndrome. As we know that GB syndrome is possibly autoimmune. So first of all is any autoimmune disease. If the patient is suffering from any autoimmune disease, they are at an increased risk of developing GB syndrome. It has association with immunizations, as we have already discussed, like certain vaccinations, swine influenza vaccination, and the recent influenza vaccination that we use nowadays. And other than that, we have meningococcal vaccination. So all these vaccinations are associated with a risk of GB syndrome, with an increased risk. Then frequently it is preceded by mild respiratory or intestinal infections, as we have discussed in the subsequent section. It can be most commonly it is a Campylobacter jejuni infection. Other than that, it can be a human herpes virus infection. It can be HIV, hepatitis E, or Mycoplasma pneumoniae. It depends on the circumstances. Then we say that GB syndrome usually begins in the hands and feet, and it progresses over hours to days. There is minimal muscle atrophy, begins in the lower extremities, and then it ascends bilaterally. This is the most characteristic of GB syndrome. There is muscle weakness. The patient might be experiencing ataxia. They might have difficulty walking, or they may be swaying away from their center of gravity. There will be bilateral paresthesias, which can progress to paralysis. The paralysis is always symmetrical, and due to this progressing paralysis, there can be certain problems associated with it, such as if the paralysis reaches the respiratory muscles, patient might have difficulty breathing. They might have difficulty talking if it involves the muscles of tongue. The patient might have difficulty swallowing, or they may be experiencing bowel and bladder dysfunction, which can lead to incontinence. And if the patient is suffering from acute illness, they might experience respiratory problems. They have difficulty breathing, so we have to give them ventilatory assistance. So as we say that it is a rapidly evolving areflexic motor paralysis with or without sensory disturbance. I have already told you that it begins in the lower extremities and then it ascends bilaterally. The legs are first noticed as rubbery in appearance. There is muscle weakness and tingling dysesthesias in the extremities. The legs are more affected than arms, and the patient might experience facial diaparesis in 50% of the cases. What does that mean is the patient will have a paralysis or paresis of lower half of one side of the face, and it is mainly due to the involvement of upper motor neurons. If there are lower cranial nerves involved, they will present as bulbar weakness. The patient will have difficulty in swallowing or chewing or during mastication. They will have difficulty handling the secretions. So the patient might present to us with incontinence, urinary or bowel incontinence. And if there is respiratory involvement, we will have to maintain the airway so that the patient can breathe easily. Certain other manifestations are pain in neck, shoulder, back, or spine. It occurs in around 50% of the patients. And if in a patient we find fever and constitutional symptoms, what are constitutional symptoms? These are all the symptoms that are generally present in other systems of the body, such as malaise, fever, weight loss, and anorexia. If we find that the patient is also complaining of these symptoms, we will suspect the diagnosis, because a GB syndrome patient will never present with fever and all these constitutional symptoms. Deep tendon reflexes usually attenuate or disappear in case of GB syndrome if there is lower motor neuron involvement. Cutaneous sensory deficits such as loss of pain and temperature, these are mild, but functions that are subserved by large sensory fibers like deep tendon reflexes or proprioception, such kind of functions are severely affected. Then we have already discussed that there is bladder dysfunction, which is found in GB syndrome. Most patients require hospitalization, especially those that are suffering from the acute infection. And up to 30% of the patients require ventilatory assistance if there is involvement of the respiratory muscles. Mechanical ventilation in more severe weakness on admission. And there is a rapid tempo of progression. It ascends bilaterally in a symmetrical pattern. And there are presence of facial or bulbar weakness during the first week of symptoms. Now we will see what happens in case of autonomic involvement. If the autonomic nerves are involved, there is loss of vasomotor control, and it is very common in GB syndrome. There will be wide fluctuation in the blood pressure, and a patient, due to these fluctuations, the patient might experience postural hypertension, cardiac dysrhythmias. So these patients require close monitoring and management because autonomic involvement can be fatal. GB syndrome patients experience several kinds of pain, out of which there is deep aching pain in the weakened muscles, and another type of pain is due to the involvement of sensory nerves, that is dysesthetic pain in extremities. But this pain is usually self-limited or it responds to the standard analgesics, and it's not very severe. So this was all about the clinical features of Guillain-Barré syndrome. Keep watching sqadia.com.